good afternoon to everybody. Thanks to the moderators for the introduction. And so, as we have seen today, there are 2 points for our instability that are critical. The bone loss on the glenoid, but also the Hill-Sachs lesion. As Di Giacomo and all the others taught us, the problem is especially when the Hill-Sachs is medial. And actually, when the Hill-Sachs is medial, remplissage is not effective. But in any case, this is a problem to face. So the diagnostic algorithm is the same, but let's focus also on the Hill-Sachs, because when we have seen if there is a concomitant bone defects on the glenoid, we have to see if there is a Hill-Sachs, and most of the time there is, it exists. It's important to know the localization. The localization more than everything, because as Di Giacomo himself said, on practical daily life for us, it's not that important to calculate this on track, off track. If you have a bipolar bone loss in a guy with the characteristic that can dislocate again, this is a perfect candidate for a bony reconstruction. But bony reconstruction is not only the glenoid. Hill-Sachs is a defect of the bone. And so I never liked non-anatomical techniques. I don't like Latagé, despite the fact I recognize that it's useful in many times. I don't like remplissage. And so for many years I was looking for something different. So this is a classical case, 25 years old, left shoulder dominant hand worker, playing soccer, and you have first time of anterior dislocation not longer than 3 years, and 5 episodes. There is this is the physical examination. There is a Hill-Sachs lesion, like this. And there is a concomitant small defect in the anterior glenoid. So this, for me, is not a candidate for Bankart plus remplissage. But in any case, there is no consensus what to do. I mean, as we have seen, many surgeons, they do different things for the same patient. In any case, for me, this patient is a perfect candidate for the Hill-Sachs filler, something that we have created for filling the Hill-Sachs and reconstruction the damaged humeral head sphericity with the insertion of an osteoconductive bone substitute. So something that can fill with bone the Hill-Sachs. So we started in 2017. We thought about placing peak prosthesis, but we were not happy about the technique, plus considering the possible migration if it was not integrated. So we tried that on the cadaver, and we were quite happy about the fact that we were quite good in recreating sphericity of the humeral head. But then we tried the bone substitute using allograft and xenograft. And in the lab, we were able to create an instrumentation that allowed us to place the graft very well aligned with the humeral head contour, and avoiding what is the most difficult part of this technique, the misalignment of the filler. Because if you're not perfectly perpendicular to the Hill-Sachs, you insert in one side too deep, and the other side is going to be proud. So basically not effective. So departing from the fact that the humeral head can be considered as a sphere, we have to have a guide that let us place a guidance wire, a Kirchner wire, in the center of the humeral head. If you can achieve that, then you can be precise in placing your graft. And we have created this instrumentation, and especially the cannulated centering device allows us to do this. And if we place this device that touch on the 3 sides, the part proud of the Hill-Sachs lesion, then we are pretty sure that our guidance wire is going to be in the center of the humeral head. We have tried, of course, first on the cadaver, and we were quite surprised how good we could be. And then we passed on the wet lab, and we have seen that we were pretty good in placing this graft, And also, we were quite amazed about the fact that this graft, they can mold around the defect of the Hill-Sachs. And so, even that allow us to be very, very precise in feeling the defect of the Hill-Sachs lesion. So, regarding this, we thought that we were ready to use on the human and in the patient. This is a case, the case that I showed you before. So Hill-Sachs lesion and glenoid lesion. So our goal is to reconstruct the anatomy. So first, we start with the Hill-Sachs. We place the scope in the anterior superior portal. We look at the Hill-Sachs in this phase. We enter with a spinal needle. We try to be as perpendicular as we can, but then we place this instrumentation that allows us to place a Kirchner wire that is going to pass in the center of the humeral head. We rim on that in order to prepare, a tunnel for allowing our filler to squeeze inside and to be stable, and at the same time to cover the Hill-Sachs lesion. So actually, after we have found the position with that guide, this is all guided by a Kirchner wire. We go on top of that. We pass through the same cannula of almost the same size of the bone block. We have two kind of cannula, 10 and 15 millimeters diameter, so we can push inside the graft up to 40 millimeters array. And under the arthroscopic control, little by little, you push down, doesn't break, and squeeze into the hole that we have made that is 1 millimeter smaller than this. So, at the end, this is going to be press fit inside the hole. And we can cover our Hill-Sachs lesion. When this is almost inside, we have another instrument that allows us to squeeze it almost perfectly inside. So as you can see, it's a guided technique, no challenge. And thanks to this guide, we have just to press. At this point, when it's everything inside, we remove the Kirchner wire, and we enter with the second instrument that allows us to squeeze it better, and this doesn't break, just it molds, as I said, in the Hill-Sachs. And this is the post-operative. There is the bone block, there is the filling of that. So at the end, with this bipolar bone defects, I've recently changed my algorithm. I think that where there is the indication for the bone block, if there is a concomitant Hill-Sachs, we add to the bone block Hill-Sachs filler. So this is a reconstruction of the real anatomy of the joint. We put bone on the anterior glenoid when it's missing. We reconstruct the capsule, we repair the bankert, and we fill the Hill-Sachs not with a tendon or a capsule or muscle or whatever that is not anatomical, but osteoconductive graft. And especially when the Hill-Sachs is more dangerous, meaning medial, where the remplissage is not indicated, I think this is a viable alternative to that. Of course, it's about 5 years we're working on this, but the first cases, they have just a very short follow-up. So I cannot tell you anything about the fact that the CT scan post-operative, they look good. We will see about the results in about 1 and then 2 years. So I'll keep you updated. So in the end, the Hill-Sachs filler technique can be used in conjunction and is synergic with all the stabilization techniques, because of course it's up to you. You can, if you have a Hill-Sachs lesion, you can do a DAS, you can do an ASA, and then in the end you can fill the Hill-Sachs. We have a lot of patients that they have just a huge central Hill-Sachs and almost no bone damage on the anterior glenoid. So anteriorly you do a soft tissue, whatever soft tissue you want, and then you do this in the posterior part. So, this is something that is really kind of my philosophy for a stable shoulder. Whenever it's possible, my preference is always to try to restore the normal anatomy. And I think this should be the goal, to fix these patients with instability. This is what we achieved, in the lab, and that was pushing me to try to speed up as much as we could with this small Swiss company where I created this instrumentation to go on with this. Thank you very much for the attention.